First of all, I also want to thank the organizers for inviting me to present here at this meeting. It's a fantastic venue. I'm going to speak about an update about diabetic nephropathy management, and I'm starting off with some more established regimens and then moving on to some more novel treatments that still need to be confirmed that they actually are effective in the clinical context. So some of the treatments that work, that we know, is intensive glucose control. And this is some data here from a recent analysis, including a range of studies that compared intensive versus standard anti-glycemic therapies, and there was a clear reduction in the microvascular events with this approach. And this is also supported by some more recent data from the ADVANCE trial, where standard versus intensive glucose controlled reduced the incidence of ESRD by about 65%. Furthermore, there was an analysis here by Sophia Zugas, also on data of the ADVANCE trial, showing that the two approaches used in this study, a standard versus an intensive glucose lowering regimen, and also a standard and intensive reduction of blood pressure using the brindapel-idapamide combination. And using those two approaches had an additive effect, not only here, as I show here, on the macroalbuminuria, which was really quite significant by 55%, but also on end-stage renal disease. We also know that a multifactorial approach works well, and these are data here from the STENO trial, which included interventions targeting blood pressure, glucose, and lipids. And you could see here in the 7.8 years follow-up, there was a significant reduction in incident macroalbuminuria, and this was even true after the additional 5.5 years of follow-up. Then we have some agents that are given in a different context for triglyceride therapy, but also have been shown to have renoprotective effects, such as fenofibrate used in the FIELD trial. And in this analysis, you see that microvascular complications, such as retinopathy and progression of albuminuria, were reduced. And the mechanism here seems to be independent of lipid lowering and might even involve factors like VEGF. The more novel treatments used in glucose therapy include agents such as GLP-1 agonists or DPP-4 inhibitors. And there's a range of experimental studies that show that they might have renoprotective effects. This here are some pooled data analysis from 4 trials presented at ADA last year, that there is evidence that these DPP-4 inhibitors have renoprotective actions on top of ACE inhibitors and ARBs in diabetic nephropathy. And this was evident here after 12 weeks and also after 24 weeks. And this is most likely independent of their glucose-lowering effects and can involve other factors such as BNP and growth factors. And then we had some new agents on the market that looked very promising initially in smaller trials. This was the BEAM study looking at different doses of the NRF2 or KIAP agonist bardoxolone, which is an antioxidant or initiates antioxidant pathways and changes the balance between ROS production and antioxidant defense. And this looked very promising actually in increasing reduced VEGFR in patients with chronic kidney disease, stage 3B and 4. And you see these patients started off with quite a reduced renal impairment and their renal function improved, and this was sustained over the 52 weeks of the study. Unfortunately, the follow-up trial, Beacon trial, and probably a lot of you were involved in this, was then stopped prematurely due to safety concerns, and they were mainly cardiovascular, of cardiovascular nature. A similar story was also observed for Alice Kieran, which was initially looking very promising in the AVOID trial, on top of losartan, reducing albuminuria and potentially also providing more cardiovascular protection. But in a larger trial, the Altitude trial, looking at cardiorenal endpoints, the trial was either ineffective or even had more severe side effects, such as hyperkalemia and hypertension. The endothelin system has also been implicated in the pathogenesis of diabetic nephropathy, and specifically the ETA receptor. And there were some studies using avusentin, which is more ETA receptor specific, and showed promising results here on top also of ACE inhibitor and ARBs in reducing albuminuria. And this was studied in 2010. But then the larger trial, the ASCENT trial, again had to be prematurely terminated because there were some side effects related to fluid retention and heart failure. And this could have been due to an activation of the ETB receptor, but it left the door open to the development of more specific ETA receptor antagonists, which are also currently in investigation, and they are, for example, atrasentan. And in this study, we can show again here that the endothelin receptor blockade was successful in reducing albuminuria on top of ACE inhibition in diabetic patients. But most of these therapies do not really attack the underlying molecular pathways that are activated in diabetic nephropathy. And we believe that one of the common downstream factors is NADPH oxidase activation and the production of reactive oxygen species. And this can be activated by glucose-dependent pathways, which are present in diabetes, but also via hypertension-derived pathways such as activation of the renin-angiotensin system. This upregulation of ROS then leads to signaling pathway activation and transcription factor activation such as NF-kappa B, leading to a range of pro-inflammatory and pro-fibrotic factors. So the NADPH oxidase is one of the only enzymes that is a professional oxidase, so it does nothing else than producing ROS. And a range of other enzymes also involved in the production of reactive oxygen species. That the ROS is more like a byproduct of their activity. So our focus more recently was on the NADPH oxidase-derived ROS in diabetic nephropathy. A range of isoforms are known to be present, and initially the focus was on NOX2, which is present in leukocytes and macrophages and in phagocytes, and it plays an important role in defense mechanisms. But more recently in the kidney, NOX4 is actually the isoform that is present already in a basal state in high concentration, and it was initially called Renox. So, looking at NOX2 deficiency in diabetic nephropathy, the first thing we noted when we make NOX2 knockout mice diabetic with STZ, we have a significantly increased mortality. And this is due to overwhelming sepsis. So these animals need to be treated with antibiotics. Right from the beginning, they are made diabetic. So it does appear that complete NOX2 blockade is probably not a feasible target, at least in diabetes. But this doesn't exclude that a partial NOX2 blockade could be renoprotective. But again, we look now in these animals, in these knockout mice under the protection with antibiotics. But after 20 weeks of albuminuria, we did not see a renoprotective effect. If at all, there was an increase in albuminuria. And looking at glomerulosclerosis index, there was no protection. And also at the tubular interstitial injury, there was no protection, if at all, a tendency to a worsening. And this has now been published. So the focus then was on NOX4, which we know is well presented well expressed in the kidney. And these are studies here from Gorin and Aboud's group, published a while ago now. They showed that here NOX4 protein was significantly upregulated in the diabetic kidney, and that silencing of this NOX4 in a short-term experiment for 2 weeks using an antisense approach was associated with renal protection, for example, fibronectin expression. This is just showing here the NOX4 expression and the effect of the silencing approach. These are now some data from our group. Again, we could show increased NOX4 and NOX1 gene expression in the renal cortex in diabetes. And I should point out we use as a model the apolipoprotein E knockout mouse, which is prone to more advanced kidney disease and also to macrovascular disease. So it's a model to address both issues in diabetes. We could show that NOX4 was also upregulated on the protein level, and here's some immunofluorescence data demonstrating this. So what we did next is cross the apolipoprotein E knockout mouse with a NOX4 knockout and with a NOX1 knockout mice to delineate the role of those two isoforms in diabetic nephropathy. And we made these mice diabetic at 8 weeks of age and followed them for 10 weeks and 20 weeks. And what we could see was that NOX4 deletion in diabetic ApoE knockout mice tended to reduce the albuminuria development after 10 weeks, but there was a clear reduction after 20 weeks of diabetes. This effect was not observed in the NOX1 deleted mice. And fortunately enough, we had also access to a novel inhibitor of NOX. This is a NOX1, NOX4 inhibitor. And I should point out that the research in this area has been hampered for a long time because there were no specific inhibitors available. So most NOX inhibitors also had other effects on other oxidative or antioxidant enzymes. So this is the first really available pharmacological inhibitor that is specific for NOX1 and 4. Treating normal diabetic ApoE knockout mice, so they express NOX1 and NOX4, with this compound for either 10 weeks or 20 weeks was also associated with a significant reduction in albuminuria. And this mimicked really the findings here in the NOX4 knockout mice. These anti-albuminuric effects were also mimicked with other effects on renal protection. I'm just showing you one example here. The fibronectin expression was significantly reduced in the NOX4 deleted mice. This effect was not seen in the NOX1 knockout, but it was observed again with a pharmacological inhibitor in diabetic ApoE. We also looked at the podocyte, as the previous speaker has alluded to, because it is a very important cell in the regulation of albuminuria and proteinuria. And we should demonstrate NOX4 presence and an increased and changed expression in high glucose conditions. We then looked at ROS production in this human podocyte line with high glucose and TGF-beta, which was significantly elevated, and silencing of NOX4 using an shRNA to NOX4 attenuated this ROS production. And this was also associated with reduced expression of profibrotic markers such as collagen 4, fibronectin, and VEGF, and a tendency for alpha-smooth muscle actin. Most interestingly, and from a lot of the previous agents that were under development, it has become clear that sometimes renal protection is not always associated also with macrovascular protection, and indeed sometimes these are the side effects that were observed. But in this model, the NOX inhibitor was also associated with a reduced plaque formation in the aortic arch and in the total aorta, and this just been published in Circulation. So we think that metabolic factors and hemodynamic factors, as they are activated in diabetes, lead to an upregulation of ROS, ultimately leading to diabetic nephropathy. But we also know in diabetes that the formation of advanced glycation end products, such as AGEs, and their early precursors, such as methylglyoxal, they're very reactive decarbonyls and very toxic, and contribute to, first of all, intracellular protein glycation, matrix modification, but also to AGE plasma protein modifications, binding to receptors such as RAGE, activating ROS, NF-kappa B, growth factors and cytokines. So in the last few slides, I'm just going to talk about AGEs. So we had previously shown that AGE inhibition is successful in reducing glomerulosclerosis and tubular interstitial injury. We used aminoguanidine and a more novel compound, alagibrium, and aminoguanidine has been taken into the clinic but was also stopped again due to side effects. But both AGE inhibitors were able to protect renal injury. Another approach was RAGE deficiency, and also this was effective in reducing renal injury. Clinical trials have evaluated AGE inhibitors such as pyridoxamine, and an initial study looked very promising, in particular with patients with elevated creatinine. A more recent study is a little bit less optimistic, and there was a slightly weaker effect and more in patients with less advanced disease. But this still needs to be confirmed. Our own trial, short-term trial, we performed with alagibrium in type 1 diabetic patients with microalbuminuria on top of ACE inhibitor, showed a significant reduction after only 12 weeks of treatment. And this was associated with a reduction of circulating methylglyoxal, which is a precursor of AGEs and, as I said, a reactive decarbonyl and toxic. So in summary, there are some established approaches such as intensive glucose lowering and blood pressure control, and this of course will include RAS blockade. A multifactorial approach has been shown to be successful. There are some novel treatments on the playing field which still have to be proven. There's some promising early data, but again, what we find in a mouse is not always replicated in the human context, and one has to be careful in making those translations. The targeted antioxidant therapy appears to be promising, but this still needs to be confirmed on the background of renin-angiotensin system blockade in a phase 2 clinical trial. Now, thank you very much for your attention. These are all the people I need to thank.